afternoon, everyone. Thank you so much for coming out. We've got a great turnout so far. I know we're going to have a few more folks trickling in, but I will go ahead and get us started. My name is Luke Hansen, and I'm a program manager with the University of Alabama at Birmingham School of Public Health's Office of Public Health Practice. And it is my pleasure today to welcome you to Epidemiology 101, Fundamental Concepts for Understanding the Pandemic, featuring Dr. Stella Aslebekian from 23andMe. This webinar is made possible by the Alabama Regional Center for Infection Prevention and Control, Training and Technical Assistance, or as we call it, ARC-IPC. ARC-IPC was established to meet the consultation and support service needs surrounding infection prevention and control throughout the state of Alabama. The center is a collaborative effort of the Alabama Department of Public Health's Infectious Disease and Outbreaks Division and the University of Alabama at Birmingham. ARC-IPC provides training and technical assistance to infection prevention and control and public health professionals in areas needed to detect, respond to, control, and prevent infectious disease outbreaks. You can learn more about the center, view and listen to past trainings, webinars, and podcasts, request training and technical assistance, and view infection prevention and control resources at our website, uab.edu/ARC-IPC. You can also email arcipc@uab.edu with any questions, and to stay up to date about future trainings by signing up for our newsletter on the homepage of our website. We also want to take a quick moment to thank our co-sponsors for today's webinar. That would be the Deep South Center for Occupational Health and Safety, as well as the Region 4 Public Health Training Center. And again, you can see their information here, including their websites, to learn more about those organizations. We do quickly want to shout out our next webinar and hope you'll join us for that. Featuring Dr. Adam Brooks, will focus on difficult dialogues, learning effective communication about tough topics. And really in today's polarized and increasingly isolated communication landscape, we all know it can feel impossible to break through some of the noise out there and establish a meaningful dialogue about issues related to the COVID pandemic and everything associated with it. And so in this webinar, Dr. Brooks from the University of Alabama will share the basis for effective communication and how to shift and how to discuss tough topics from a debate to a dialogue setting. Webinar will be presented by the ARC-IPC and co-sponsored by the Region 4 Public Health Training Center, and it'll be held on March 10th at 12 p.m. Central Standard Time. Continuing ed credits have been approved for nurses by the Deep South Center for Occupational Health and Safety for this webinar. To receive credit, you need to register for the training, watch the entire program, and complete the evaluation following. And then upon completion of the evaluation, you'll be redirected to the Alabama Nursing CEU request form, which you'll also need to complete. The CEUs will be awarded by the Deep South Center for Occupational Health and Safety, and you don't have to submit directly to the Alabama Board of Nursing. These CE units will expire on February 24th of 2023. And then if you have any issues, please email ARC-IPC and we will place this email in the chat box as well. So again, any issues with CEUs, just let us know. And finally, it is my pleasure to introduce our speaker. So Dr. Stella Aslebekian is a senior scientist in genetic epidemiology at 23andMe, as well as an adjunct associate professor of epidemiology at the University of Alabama at Birmingham and the University of Kentucky. She earned her undergraduate honors degree from Stanford in 2005, and then that was followed up by public health training at the Harvard School of Public Health, and then at Brown University, where she earned her PhD in 2011. Throughout her research career, she has focused on the nature and nurture question, specifically how genes and environment interact to determine disease risk. She's investigated this question in diverse populations using complementary approaches. Dr. Aslebekian's work has been funded by the National Institutes of Health, as well as the American Heart Association. Currently, she works on integrating large-scale nature and nurture data available at 23andMe to improve models of disease in human populations. And so with that, it is my privilege to turn it over to Dr. Aslebekian.
Thank you, Luke, for this generous and wonderful introduction. I also enjoyed watching the chat, and it sounds like a lot of people are joining us from different parts of the country. And I'm joining you from Northern California, where it is also unseasonably cold. I wanted to acknowledge the challenge of giving a lecture such as one. I was asked to provide an introduction to epidemiology, and that's hard. I mean, that's been my life's work. This is the field in which I earned my PhD, and this is the field I've been practicing for the past 10 years or so. And very often epidemiology is touted as the basic science of public health. So, and of course, I suspect that the reason you guys invited an epidemiologist in the first place is because epidemiology has gone from being a relatively obscure science to a household concept. and that'll happen sometime in the spring of 2020. So my goal for today is to introduce enough epidemiologic concepts to you to start thinking about the pandemic as we would think about the pandemic in our discipline, to start evaluating epidemiologic evidence, and to start really critically thinking like an epidemiologist would about the news and peer-reviewed literature that may be coming out, actually coming out very quickly during this pandemic. So I know this is a very educated crowd, lots of healthcare providers, lots of nurses, and I don't mean to insult anybody's intelligence by starting with a pretty basic definition, but I think this definition is very informative. So the CDC has this very formal way of describing epidemiology. We study the distribution and determinants of health-related states or events in different populations, and then we apply that knowledge to try to actually change public health for the better. But before we decode what that actually means in plain English, I would like to go back to the Greek roots of the word epidemiology. You could translate it as the study of epidemics, but even the word epidemic actually consists of two Greek roots. Dem is demos, people. That's the same dem as you see in the word democracy. And then epi, it's the same as epidermis, the top layer of your skin. This is what happens to the people. This is what happens in some sense on top of the people. This is what happens in our lives. So it's a really broad definition if you think about it. So I don't like the CDC definition too much, no disrespect to the CDC, but I think it's unnecessarily technical. Epidemiology is the study of who gets sick, where that happens, and why that happens. And as we learn those things, as we learn about those patterns of disease distribution, we can then leverage our knowledge of those patterns and actually apply it to fix public health problems, such as the COVID-19 pandemic. So in some sense, the history of epidemiology is really interesting. When I was getting my PhD, all we talked about was chronic disease epidemiology. You can see this slide is from the CDC from 2016, 2017. And you can see that heart disease was by far the top cause of death in the United States, followed closely by cancer, and then everything else. And that's been going on since pretty much the 1950s. So very early on, as epidemiology was being established as a science back in Great Britain, back in England in the 17th, 18th century, it was mostly a study of infectious diseases like cholera. But then as hygiene improvements around the world have led to pretty effective control of infectious diseases, we've really switched to looking at heart disease and cancer. And that's actually what I've spent most of my career doing. When I was back at UAB as a full-time professor, I was a cardiovascular epidemiologist. And the reason I wanted to devote my life to studying cardiovascular epidemiology is because it was killing so many people. And that changed very quickly in 2020. You can see here a couple of really interesting statistics. So this is a graph of deaths per week. It uses slightly different units, actually very different units from what I showed you on the past slide, but you can notice a couple of interesting things here. So first of all, heart disease and cancer. You know that consistently those two groups of conditions have been killing Americans and really folks worldwide at pretty high rates. You see that those conditions, the deaths from those conditions, have an interesting seasonal pattern, that even outside of the pandemic, there is always a spike around Christmas and New Year's. So that's also something we know, and we can think about, well, what does that mean about the etiology of those diseases? What does that mean for potential prevention strategies of those diseases? But those seasonal patterns are one thing to note on this slide. The other thing to note on this slide is we've always had deaths from infectious diseases, particularly in vulnerable populations. You can see here that the flu is on the bottom, plotted as an orange line. It also shows a similar, albeit not as striking, seasonal pattern, but it's there, and it's there at a much lower rate than heart disease and cancer. And then everything changes in 2020. I have to admit that when I first saw the numbers, I didn't take it particularly seriously. It wasn't until my former classmate and friend tweeted about the R0 of the pandemic, and we'll talk about what that is, that it started looking unusual. But you can see here that pretty quickly, and this graph really ends before the end of 2020, but you can appreciate here how quickly COVID-19 took over even heart disease and cancer as the top cause of death in the United States. And this is exactly what we see in 2021 as well. These data are from the Kaiser Family Foundation, and you can see here that COVID-19 in 2021 has overtaken both heart disease and cancer. And we still have deaths from all these other conditions. At the time of me preparing this lecture over the weekend, we haven't quite gotten to 1 million COVID-19 deaths, but unfortunately, that'll probably happen in the next few weeks. So there is no doubt that this pandemic has taken its toll and presents probably the most important challenge to epidemiologists of my generation. Now, I do want to say a few words on the causes of death. How do we establish causes of death? How does the CDC do that? And the CDC relies on public records, specifically from death certificates. Now, many of you are clinicians, and unfortunately, perhaps you've had to fill out a death certificate. And you know that the CDC advises healthcare providers to use their best clinical judgment. So why am I bringing that up? There's been some skepticism out in the media saying that, well, if somebody tested positively for COVID-19, even if they died of something completely unrelated, even if it's a young and healthy person who passed away as a result of a car accident or death by suicide, as long as they tested positively for COVID-19, they would still be counted as a COVID-19 related death. That is not true. Now, what we do see a lot with COVID-19 statistics are the effects of comorbidities. If we have a patient with cancer who is hospitalized and tests positive for COVID, and the clinician established that this person's deaths was precipitated or accelerated by COVID-19, well, in that case, yes, it would be counted in those statistics by the CDC that I just showed you. But it's important to understand those nuances. And if anything, we now have evidence to believe that early on in the pandemic, because we didn't have enough tests to establish a COVID-19 status for every patient, and people were dying fast, if anything, early deaths are likely to be undercounted rather than overcounted. So unfortunately, that number that I showed you on the past slide, that number that's in excess of 900,000 Americans died so far, it is probably an underestimate. So this is the context in which we're practicing epidemiology. So let's go back to why we do what we do. We want to understand patterns of people getting sick, and then we want to apply our knowledge derived from those patterns to do better in terms of public health prevention. So let's go piece by piece as we explore that definition. First one is, well, who gets sick? And in this case, we know that many of us have already gotten infected or might become infected reasonably soon. But what we really want to avoid are COVID-19 hospitalizations. What we really want to avoid are severe COVID-19 outcomes. And if you ask an epidemiologist this question now, well, who gets hospitalized? What would be the one line in the sand that you could draw that could help us understand who will get hospitalized and who will not? The biggest predictor right now of hospitalization is vaccination status. And you can see here that there's a dramatic difference between hospitalization rates among the vaccinated and the unvaccinated population. I do see a question in the chat, and as I go through the talk, I will try to pause and answer those questions, but I will ask for a little grace sometimes with those questions. So the question that Hannah has is, if the positive report happened post-mortem for the individual, would it go into the case count even if not reported as cause of death? It will not be counted by the CDC because they're pretty heavily reliant on causes of death. Again, that would contribute, if anything, to underestimation of COVID-19 related deaths in the United States. The next question and the next part of our definition is where do people get sick? And certainly it goes without saying, knowing where people get sick helps us understand the pandemic patterns better. You can see this is a relatively recent map of Alabama, color-coded by county. You can see that right now Jefferson County, where UAB is, is not doing that great, but they're not in as bad of a shape as some of the actually lesser populated counties in Southern Alabama or up on the border with Tennessee. And then, of course, there's a question of when. That also helps us understand the waves of the pandemic better. It helps us understand the emergence of new variants. It helps us understand the severity of new variants. And this is not a graph of deaths. This is a graph of cases. Again, this is also for Alabama. You can see the Delta wave here in the fall of 2021. And you also see the most recent Omicron wave in February of 2022. The most challenging and important part of the epidemiologist's work is why people get sick. This is a pretty typical diagram that illustrates the complexity of potential answers to the why question. And my personal philosophy is best described here by rigorous empathy. Sometimes it's very hard for us to understand why people engage in certain health behaviors and why people expose themselves to certain dangers and why people make certain choices the way they do because we're not walking in their shoes. And this concept of being empathetic and yet rigorous with our science is one that I hope guides my work. You can see here that severe COVID outcomes, or really pretty much any health outcome, can be linked to health-related behaviors, can be linked to, those would be things like smoking, those would be things like physical activity. They're also linked to social and community networks, to the availability of social support, to the socioeconomic status of an individual, to their education status, to their life circumstances, and of course to the macroclimate of the pandemic and to broader conditions that exist in the country and in the world. So the short answer to the why question is it's complicated, and it's on us to try to understand these circumstances with the most rigor and the most empathy to arrive at the most scientifically correct and also realistic answer to the pandemic. One example here, I remember early on in New Orleans, they were trying to implement drive-through testing sites, especially in neighborhoods that were hardest hit by the pandemic. And people didn't show up because those epidemiologists that were organizing those testing sites didn't understand that many people didn't have cars. So they changed their strategy, and instead they brought vans into those neighborhoods so people could walk in instead of having to drive through. And that, of course, changed the efficiency of those testing programs quite dramatically. So understanding people's life circumstances is really critical to being a good epidemiologist. I have another question here. So 2 questions from Alan. One, will this webinar be available to rewatch? I believe that is the case. And how is it possible for you to obtain accurate COVID-19 counts when not all states are providing that information, for example, Florida? So the CDC does have offices that are regional that can get that information. Just because the state of Florida is not providing that information to certain agencies doesn't mean that the information is not being provided at all. There are ways to contact hospitals. The state of Florida still has a Vital Statistics Bureau, and I don't remember what exactly it's called, but you can still get that information with a fairly high degree of precision because everybody who dies in the United States does get a death certificate, or let's say the vast majority of people who die in the United States get a death certificate. So, and finally, another question. Yes, Luke, thank you for clarifying that the webinar is being recorded. Let's get to the next part of our webinar, in which I will introduce a few concepts that you may hear in the media and in peer-reviewed literature that are epidemiologic concepts that are really critical to understanding the pandemic. The first one that we heard a lot, especially in the very beginning, was this idea of herd immunity. And recently, we've also been hearing more about this term of superimmunity. So let's talk about what that is. Herd immunity has been often regarded as our best hope for controlling this pandemic. And unfortunately, it reflected a gross misunderstanding of what herd immunity actually is. The idea is that when a pathogen such as a coronavirus is introduced into a population, and enough people are immune to it. When it's introduced again, it has nowhere to go, because normally if it's introduced to a naive population where nobody's immune, it infects one person and then that person infects others, and then this infection chain develops in an exponential way. This is what you see on the left-hand side of this panel. But people are immune either through vaccination or through having been sick and having developed those antibodies. Yes, one person may still get infected, but then they're interacting with people who are mostly immune, so the virus has nowhere to go. This is the idea of herd immunity, because when the virus doesn't have anywhere to go, it dies, and it does not result in the disastrous public health consequences that we are seeing now. And countries like Sweden really relied on herd immunity as a matter of government policy. They were hoping that enough people will get sick, that herd immunity will get achieved pretty quickly. And then even without vaccination, this will no longer be a public health issue. And herd immunity is different for different diseases. It depends on a few epidemiologic attributes. And the first one is the transmissibility of the virus. And this is this quantity that I alluded to earlier called R naught. And all R naught is, it's the average number of cases that result from a single infected individual in the population. So this is my friend Eric Feigo-Ding. He's an epidemiologist from Harvard. We were in grad school together, and I follow him on Twitter. And towards the end of January, he tweeted, and I don't mean to insult anybody's religious feelings, but that's the language he used. He tweeted rather emotionally that the R naught of the new coronavirus is 3.8. Now, what does that mean? Well, that means that on average, one person infected with SARS-CoV-2 will infect almost 4 people. Now, he's an epidemiologist, so he knows this is super high. I'm an epidemiologist too. I saw the same data he did. And honestly, my first reaction was, this got to be an overestimate. There's no way this is real. And of course, we know now that it was real. I did get a question, did the herd immunity approach work in Sweden? The short answer is no. And many people, particularly from the vulnerable population, died while waiting for the herd immunity. And I'll say more about why the herd immunity approach didn't work. So here's how COVID-19 compares to other infectious conditions. You can see that things like chickenpox, mumps, and measles actually have much higher R naughts. And that's why you can have a chickenpox party where enough kids get infected. And probably if you bring those 10 kids, all 10 of them will get infected from this one child who had chickenpox. You can see that, and of course, the nice thing about those 3 conditions that are to the right of COVID-19 is that we have effective vaccines against all 3 of them. But you can see that, for example, the original strain was more infectious than the 1918 influenza, more infectious than Ebola, which is why I didn't believe it in the first place, and not quite as infectious as HIV, but pretty close to that. So this is where COVID-19 sits in this continuum of transmissibility. And you see now that as the pandemic evolves, the Delta strain was much more transmissible and the Omicron more transmissible still. So that's one reason why herd immunity is not a great strategy here. It is a highly transmissible virus, and we can actually do the math. And we know that in order for herd immunity to actually take place, it would require about 70% of the population to be immune, either through vaccination or through prior infection. And as of this month, we were nowhere near this in the United States. And in Alabama, this number was unfortunately even lower. There was an estimation done by my colleagues that was quite sobering. If we solely relied on herd immunity, probably the number that I showed you would be close to 2 million deaths in the United States. So when people ask whether or not herd immunity worked, we have some pretty strong evidence to believe that it did. And there are other issues why it's not likely to work. In the US, many people are not getting vaccinated because of their beliefs about potential side effects or efficacy of the vaccine. In other countries, vaccine hesitancy exists as well, but a bigger issue is vaccine access. So because we're not vaccinating people quickly, we're likely losing the race against the evolution and the mutation of the virus. And with each evolution, with each new strain, the vaccine becomes less effective. So that number of 70% becomes higher because it's not protecting you as much as you were hoping it would. And the other thing we know about COVID-19 already is that immunity from either vaccination or infection is not durable. That's why we are now having debates about boosters when they're required, when they're necessary, and I think we're still figuring that out. But we do know for sure that immunity is not durable, and that's why herd immunity is not something we can rely on, even though in the case of something like measles, where immunity is a lot more durable, it actually used to be a strategy that we used quite a lot before the development of the vaccine. Now, superimmunity is something that I started seeing in mass media, and it's not an established epidemiologic concept, but we do see this phenomenon that I think is very interesting, that people who are vaccinated, who nevertheless got a breakthrough infection, and that is possible because the vaccine is not 100% effective, particularly against the new variants. Now, it is very effective, and in fact, I remember at the beginning of the pandemic, Dr. Fauci was hoping for an efficacy rate of 70%. Against the original coronavirus strain, the efficacy rates were closer to 95% for the Pfizer and Moderna vaccines. So those are highly effective vaccines, but you can still get a breakthrough infection. And those people who did actually had an amazing immune response compared to people who were never infected. And that was referred to as superimmunity. We now have also data that boosting is likely to achieve similar benefits. So this is not an epidemiologic concept, but you see now articles titled From Herd Immunity to Superimmunity, so I wanted to address this concept as well. Now, before we get to the next question, I think we have a question. Herd immunity would not be achieved for influenza either. That's a great question. That is probably the case. We have novel strains of the flu all the time. That's why you're asked to get vaccinated every year as best practice for influenza control. And certainly with influenza, we also have vulnerable populations that need to, I would say, again, I'm not 100% sure, but my scientific intuition, my understanding as an epidemiologist was that no, we would not achieve herd immunity for influenza either. But great questions. So let's talk about endemic, which is another term you see a lot now. The governor of California, the state where I live, recently unveiled a plan for living with endemic COVID. So what does that mean? As opposed to this epidemic or pandemic that we've been living in for the past 2 years. Now, endemic means that there is some amount of disease that's circulating in the population. It can have a seasonal pattern, and that's actually exactly the case with influenza. Epidemic refers to a scenario where the rate of infection far exceeds the situation that would be quote unquote normal in this population or typical in that population. And because the world has become much smaller due to international travel, due to our connections and trade with other parts of the world, pretty much any epidemic very quickly becomes a pandemic. And a pandemic is just an epidemic that's engulfed the entire world. Even when we close the borders, even when we go through various precautions, chances are that cases will end up pretty much in every corner of the world. And that's actually exactly what happened with the coronavirus now pandemic, which started as an epidemic in Wuhan, China. So now we are talking about living with endemic COVID. So what does that mean? So the idea behind endemic means that it's not quite herd immunity, but it's a state where people are still getting infected, but they're getting a much lower rate. And as a result, we also see fewer hospitalizations, fewer deaths. So we might still see outbreaks that are more localized. For example, we might see an outbreak at a hospital or at a nursing home, It's not the same as herd immunity. And the main difference is there's just a lot more transmission that would be allowed under herd immunity. Herd immunity is achieved for a disease like measles. Every once in a while, you hear about anti-vax parents going and there's an outbreak there. So you can still have localized outbreaks with herd immunity as well, but they're significantly rarer than with endemic disease. So if you think of it, it's a continuum, right? You have herd immunity, and then you have endemic disease, and then you have epidemic disease and pandemic disease. So we are probably not going to achieve herd immunity, but we're very likely to achieve endemic state of disease transmission. And of course, many of your healthcare providers, and you don't need me to tell you that we will always need to worry about immunocompromised individuals, about individuals that may not be able to get vaccinated for whatever reason, about individuals whose health state actually predisposes them to a more severe disease course. I have one more question. Does COVID-19 appear to have a seasonal pattern? It does. It does. And it's hard to disentangle seasonality from the emergence of new variants. So I think that muddles the epidemiologic picture a little bit, but we certainly do see a seasonal pattern. What happens is it gets colder. Right now we're in a polar vortex. We're all huddled up inside. People are indoors. They're in closer contact with other humans, and the rates tend to rise in that situation. So let's talk a little bit about incidence and prevalence. Those are measures of disease frequency that we use a lot in epidemiology, and they're quite often confused. And this is my favorite analogy of all of epidemiology. It's the epidemiologist's bathtub. So if you think about a bathtub that has a certain amount of water in it, that level of the water in your bathtub is prevalence, is the amount of disease in a population. This is how many people are currently sick in this population. You have a faucet here that's dripping new cases of disease into your bathtub, and the bathtub is the population. Now, some people are recovering, and that is evaporating. And unfortunately, some people are dying, which here is represented by the leak in the bathtub. And both recovery and mortality, the effect that they have is they lower the level of water in the bathtub, they lower the prevalence of disease in the population, but they don't change incidence at all. So that's the difference between incidence and prevalence. Incidence is how many new cases of disease are we observing in a population. Prevalence is a snapshot in time. Prevalence is the proportion of the population that's currently infected or sick. So that's the main difference between those two. I will respond to the seasonality question after we talk about incidence and prevalence. Now, when you are making policy decisions or clinical decisions, it's really important to distinguish between the two. So here's an example from the HIV/AIDS world. You have new infections, right? So you see that since 1990, the number of new infections actually has gone down because of public health campaigns, awareness, people being more careful, post-exposure prophylaxis, and things like that. Because of improvements in clinical care, the number of deaths has also gone down. And what ended up happening is the prevalence actually went up simply because people are surviving longer with HIV/AIDS. So if you're evaluating the course of the HIV epidemic, actually the HIV pandemic, if you looked at incidence, the incidence is going down, but the prevalence is going up. This is not paradoxical. This actually helps us understand the disease pattern better. And this distinction, although fairly subtle, is nevertheless relevant when we are planning public health efforts. So when I mentioned that a lot of times this gets muddled, this is a good example. So if you Google COVID-19 prevalence, what Google shows you is actually COVID-19 incidence. And you can see here because in the top left corner, you have the number of new cases. But before we get into some other epidemiologic concepts, let me address the two questions that came up in the chat. So one of them asked about the severe COVID-19 in summer in South Asia. How can you reconcile this with seasonality? Seasonal pattern is only one contributing factor to changing dynamics of the pandemic. Other things happen. For example, as I said, it often gets modeled with the introduction of new variants. And we did have new variants that emerged. We had other circumstances that could influence disease transmission and cause outbreaks. A lot of times those are sociopolitical. Sometimes they have to do with availability of resources and things like that. I am not, unfortunately, as familiar with the circumstances on the ground in South Asia, but as an epidemiologist, I can tell you that seasonality is only one factor that contributes to whether or not there's going to be an outbreak. And sometimes that seasonal pattern is actually pretty subtle. The second question, seems like the CDC did a little Orwellian newspeak. When the vaccine came out, they said it was 95% effective. Then last year, they added the words to prevent hospitalization. And yes, of course, public trust can only be gained by speaking the truth. Let me tell you that one thing I've learned as a scientist is that truth is often complicated. The vaccine was 95% effective. That came out of the initial studies of the Moderna and Pfizer vaccines, and those were published in the New England Journal of Medicine. Those were pretty clear-cut numbers. That was from that initial study preventing the original coronavirus strain. We were expecting that the efficacy of the vaccine will change as new variants emerge. I fully admit that the messaging on this may be subpar, but the truth is also not as clear-cut. And I think the CDC probably did their best. And there are lots of nuances to the pandemic that make messaging really hard. I'm glad that you guys are going to have another webinar on exactly how to talk about those difficult topics. They were correct when they said that the vaccine was 95% effective, because that's exactly what was estimated in that study. But then the efficacy estimates changed because what you see in a clinical trial is not necessarily what you see in the general population. And that's what you see in the general population in January may not be what you see in the general population in February. So the CDC has a fairly tough job, and could they be doing a better job? Of course. But this is a tough situation, and this is a tough pandemic. So let's talk a little bit about relative risks. That's another concept that you encounter quite a bit. And it's important because relative risks help understand, well, how strongly are some factors associated with the disease. For example, how strongly is seasonality associated with the likelihood of there being COVID-19 outbreak? So to calculate the relative risk associated with high season, we would calculate incidence or prevalence of COVID-19 during high season and divide it by that same number during the low season. And that will give you the relative understanding of the effect of seasonality. So I have a slightly different example here. I just brought up seasonality because one of you was interested in that. But this is a hypothetical example with hypothetical numbers, but we know that, for example, folks with diabetes are unfortunately more likely to have a lethal outcome with a COVID-19 disease. And so let's say that in that group, the incidence of death, or in other words, mortality, is 30 deaths per person week. And in the unexposed group, meaning among people without diabetes, that number is only 3 deaths per person week. And when we divide the former by the latter, we end up with the relative risk of 10. It's a ratio, it does not have units, but the interpretation is along the lines of people with diabetes have tenfold the risk of dying from COVID-19 compared to individuals without diabetes. So that's something that you see very often in epidemiologic literature, but even more often, you will see something called an odds ratio. And unfortunately, this is another scenario where two epidemiologic concepts that are closely related but not the same get confused. I know I threatened you with math, but I actually will not ruin your lunch break with it. I just wanted you to show how we calculate risk ratios and odds ratios. And essentially, those are both calculated based on how many people were exposed to a certain factor and how many of them got sick, and how many people were unexposed to that same factor, how many of them got sick. If you have those 4 numbers, A, B, C, and D, you can calculate relative risk associated with a given factor. You can also calculate the odds ratio that is associated with a given factor. And when your outcome is rare, and usually we say rare means less than 10% prevalence, For example, COVID-19 death is still considered a rare outcome by this definition. Your relative risk and your odds ratio are approximately the same, but when you're talking about an outcome like diabetes or an outcome like influenza, you can no longer think that those are the same concepts. And there's some other nuances here that are labeled by the asterisk. You can actually do a different type of study design that will enable you to estimate risk ratio from an odds ratio. But in general, those are two very different concepts. Risks and odds are different. And the way we would interpret an odds ratio, if you had an odds ratio in 10, we actually think about it in terms of odds of exposure. So we would say that among those who died of COVID, the relative odds of being exposed to type 2 diabetes were tenfold. So that is something you also may see a lot. And the reason people like using odds ratios is because you don't need prospective cohort data to estimate them. You can estimate them using logistic regression. It's just something that's easy to calculate, but it's not the same as relative risk in many circumstances. So I mentioned a few things about study designs, and hopefully this will also help you evaluate the quality of evidence that you may encounter. On the bottom rung of this hierarchy of evidence is expert opinion. So when you hear anybody, myself included, just offer their opinion, take it with the biggest grain of salt. Above that, we have mechanistic studies. So those are usually animal model studies when we observe a certain pattern in mice or non-human primates. That's interesting, and that helps us understand the disease etiology a little bit, but that doesn't mean it will be translated to humans. For example, ALS or Lou Gehrig's disease, we've had some pretty good mouse models, but they do not generalize to humans very well at all, and that's why we still don't have a good drug for ALS. Then we have case reports and human case studies. So those are not systematic investigations of disease. Those are usually healthcare providers writing up an interesting case, an interesting patient that may have been in their practice. And again, this is interesting, but this is not systematic research. Those are just anecdotes, and the plural of anecdotes is not data. Cross-sectional studies and surveys is where we start seeing data. The downside of cross-sectional studies is we're collecting information on exposures and diseases at the same time, and we often don't know what preceded what, and certainly we don't know what caused what. Case control studies also suffer from the same problem because you recruit people based on their case status. So you recruit a bunch of cases of disease, you recruit a bunch of controls, and then you go back and ascertain their exposure, and then you're able to understand their disease patterns. A better way to do it is to actually recruit people based on exposure and then follow them up to see if they will develop disease. That helps you disentangle the chicken and egg problem better. And of course, the gold standard are randomized clinical trials, which we cannot do for every outcome. We cannot do a randomized clinical trial of smoking during pregnancy, for example. To establish that that was harmful, we relied on observational data from cohort studies, because often clinical trials are unethical or infeasible or simply too expensive. But when you can conduct them, they do generate the best evidence. So I find this pyramid very useful. It lets you understand just how skeptical you need to be about evidence that came from different types of studies. Can you calculate incidence in a nested case control study? Yes, you can. So a nested case control study is one that's nested inside an existing cohort. There's another variant called a case cohort study. And what happens in a nested case control study is as new cases of disease emerge, you take them as your cases, and then at the same time, you select your controls from that same cohort. And in this case, because you have the denominator, you have data on the entire cohort, and you have the numerator, which are your cases, you can estimate incidence. Again, those are more technical questions, and I'd be happy to also talk to you later about that. So cohort studies, especially, I really like this comic about a big study linking cell phones to cancer risk. And of course, if you look, so this is actually, even though it's a web comic, this is actually a true graph. So what preceded what, this is obviously tongue-in-cheek, but it helps you appreciate the importance of having good temporal evidence. You really want to know what came first, the chicken or the egg. And that brings me to really the last point that I want to make today. And this is this adage of correlation not being causation. This is something that we have to deal a lot with in epidemiology. And so today I will go through 3 brief examples that can show you when correlation is not causation. So one example came from my work at 23andMe. I was looking at a cross-sectional study of meat consumption and the risk of colorectal cancer. Now, we know from many, many other studies that processed meats are considered a carcinogen, particularly in the setting of colorectal cancer. So in fact, the International Cancer Research Institute, which is quite a rigorous group of scientists, they have labeled processed meats as 1 and red meats as 2A on their hierarchy of evidence. So that they're pretty sure that there is a link between those meats and colorectal cancer. And yet when I was looking at the 23andMe data, we saw the opposite association. We saw people who were diagnosed with colorectal cancer, and yet they were less likely to consume red and processed meats. So why is that? Well, it's a chicken and egg question, because we asked them about their red meat intake and their cancer diagnosis in the same survey. So by definition, if they told us in that survey that they had cancer, they already knew they had cancer. So many of them have heard about this association from their doctor and already changed their diet. So what we were seeing is something called reverse causation. So it's actually the diagnosis that's causing a change in diet rather than diet causing the diagnosis. And that's something that we see quite a bit. We did have a question, did athletes playing in the polo grounds in NYC actually have a high risk of ALS? I'm not familiar with that specific example. Athletes in general do have a high risk of ALS, and it's believed to be due to traumas. So I don't know about that specific question. There could also be environmental component. ALS is a multifactorial disease. Unfortunately, I cannot tell you much more than that, but I wouldn't be surprised based on what I know about ALS in general. So that was my first example, and that's a reverse causation. The second example is a little bit different. It's also a cancer example. So we, in an observational study conducted, I believe in Greece, we saw an association between coffee and pancreatic cancer. And unfortunately, that caused quite a bit of alarm, and people started saying things like, oh no, coffee is causing cancer, you should really stop drinking coffee. Well, as you can see, I have no interest in doing this. So I was very bothered by this evidence until I thought about it a little bit more, and until other smart epidemiologists also thought about it a little bit more. So what happens in many countries when you drink coffee? You enjoy your afternoon cup of coffee alongside a cigarette. Now, that may not be something we see these days in the United States, but if you travel to Europe, particularly Southern Europe, that is absolutely what you see. And smoking is something that's not causing your coffee intake, but it's something that is really clustered tightly with your coffee intake. And we know that smoking does cause different types of cancer, and it is causally associated with pancreatic cancer. So it's not here that coffee is causing cancer, but we see a statistical association, a correlation, if you wish, between coffee and cancer, because coffee is clustered with smoking. And here we have an association between smoking and cancer. Now we can statistically adjust for smoking and take care of that, but that is also something called confounding, and that's incredibly common in epidemiology. And that can often explain the statistical association in your study. Last question here, do we know anything about the stealth variant, or is it too soon to know? Will it supplant the Omicron variant? Most likely, yes. Is it too soon to know? Sure, we're still getting evidence on that. That takes time, but we're fully expecting that it will supplant the Omicron variant. We don't know, for example, if it will be weaker or stronger, because we've seen both patterns with different variants. We don't know enough about it to really understand its impact. But will it supplant Omicron? Probably, yes. And so finally, the third scenario, and those are just 3 of the most common scenarios. There are many others where correlation is not causation. So this one's called selection bias. On the x-axis here, you have academic ability, and on the y-axis, you have athletic ability. In the general population, which is here in blue, those things are not really correlated. You have a line that we fit through the data that's almost flat and it's almost at zero. So the association between academic and sporting ability is almost zero. This is it if you look in the general population. But if you only looked among students of an elite school, so I have Stanford here in my backyard. If we only looked among Stanford students, we actually see a negative correlation between academic ability and sporting ability. Now, why is that? Well, because getting into Stanford is predicated on one or the other. You either get in because you're a top athlete or you get in because you're smarty pants. Probably not both. And because of that, you see this negative correlation. This is not at all to imply that those who are athletically gifted are not as bright, but this is a pattern that you will see when selection into the study itself, selection into the population itself, is gated by another factor. This is something that we see in COVID. For example, if you look at patients who are hospitalized, and if you're trying to ascertain the effect of some exposure among those who are hospitalized, you might get a different result than looking at the general population because of this phenomenon of selection bias. So my biggest takeaway for you today is that those are all thorny questions, and correlation is almost never causation. I think this applies to both statistics and epidemiology. I like this comic as well. I hope this gives you an appreciation for the complexity of those questions. I hope it imbues you with healthy skepticism. That does not mean conspiracy theories. That means really taking evidence at face value and continuing on this journey of learning how to evaluate evidence and how to apply it to the own decisions that you make in your personal life and clinical practice and at the public health level. I will be happy to answer other questions. I do have another question. Do you think we'll still see isolation and quarantining in the schools with the new variant? I'm a school nurse, very hard. So first of all, as a parent, let me express my appreciation for the work you do. I can only imagine how hard it is. And that's true for all of you, nurses and other healthcare providers who came to the seminar today. So thank you. You guys are the heroes. I just do the math. I think it'll depend on also the state and their risk tolerance. So in California, for example, our schools are open, but my kids do wear masks to schools. I think people are quite tired, and the mental health impact of the pandemic is really coming to the forefront right now. So I do not think that schools will necessarily close again. I really don't see that happening. But I think especially in California, we're going to see continued masking. Fourth vaccination, that's definitely still up for debate right now. I've seen data that are really mixed. We don't know if we're going to require fourth vaccination. Probably yes, but we don't know when yet.
And once again, folks, just our website, uab.edu/archivepc, or if you just Google archivepc, it'll come up there and it'll be in our archive. Just a couple minutes left. If there are any final questions, please slip those either in the Q&A or the chat.
I have a close family member with low immunity for cancer treatment. What is the future of those folks? I think the vaccines are really important for this particular population. The future is careful. If this was my loved one, I would just try to protect them as much as possible. Aside from COVID-19, are there any other areas of epi you're passionate about? I'm very passionate about genetics. That's actually my first love. I'm passionate about cardiovascular disease because most people in my family died of it. And I think this question of genes and environment and how they intersect in disease causation is really important to me. And that's actually why I work for 23andMe, which is a genetic company, because I get to play with those questions. There's not much data in the US on immunity from natural infection versus vaccination. Do you foresee more studies in this area? And is the current data supporting less need for vaccine mandates? I would say the current data are not supporting less need for vaccine mandates. It's very hard to do those studies because more than half of the population is vaccinated. And people who are not vaccinated are usually quite different from the vaccinated people in other ways. So it's really hard to do those comparisons. Again, at this point, the data do support the importance of vaccination. Of course, that can change and we need to be open to the data, but that's my best understanding of the evidence at the moment. The best thing, actually, just based on data alone, I'll just tell you quickly, the best thing is to get vaccinated and then to get a breakthrough infection. That actually gives you the best protection. It's a little interesting, right? But that's what the data show. Unfortunately, part of it is the vaccine mandates protect those kind of more vulnerable population who may not survive a breakthrough infection. So that's, I think that's the biggest reason for vaccines. And that one is still there.
All right, well, we are at 1 o'clock Central. Chris, I know you always like to get us out here right on time. So thank you everybody so much. I think this was easily one of the most robust presentations that we've had. So thank you for your attendance. Please join us. I've talked to Adam Brooks on effective communication. But otherwise, Stella, I'm sorry. Thank you so much. And yeah, this has been fantastic. So everyone, thank you again for attending and have a great day.
Thank you. Bye.